Hello, Carmelo. Hello to everyone. Thank you for attending this webinar today. So today, the idea is to talk a little bit about the anatomy of TMJ, also talking about the fascial anatomy to see how we have connection between different segments. Then we will review some literature about the effect of manual therapy in temporomandibular dysfunction. And we will present this study that we did at the University of Rio de Janeiro using AFM for temporomandibular disorder. And from this study, we'll try to understand, to give some clinical guideline for treat patients with temporomandibular disorder. So, the temporomandibular joint, of course, is made by bone component. And so we have example here, the temporalis bone, the mandible, the interarticular disc, and all the muscle of the mastication. Is a type of joint, is a synovial joint. And when we are talking about the muscle of mastication, some muscles that are very important can be classified according to the function that they execute over the TMJ. So we have the temporalis, the masseter muscle, the medial pterygoides, which they have the function to elevate the mandible, the depressor, where we have the supra and the inferior muscles, and the lateral and the protruder movement, like the lateral pterygoid muscle. And in terms of fascial anatomy, we can have a look here at the deep fascia of the head, which is particularly important in terms of masticatory muscle. So some of the important fascia are the temporalis fascia around the skull region, the parotid masseteric fascia in the face, the pterygoid fascia, and also the buccopharyngeal fascia. So we will now quickly speak about this type of fascia to understand also the connection that we have from the area of the head to the area of the neck. And I think it will help us to understand the first thing that is very important in the manual therapy for the TMJ dysfunction, that we should have a more global approach. The temporalis fascia, so is a fascia that is in continuity superiorly with the epicranial fascia. It covers all the temporalis muscles. Inferiorly, basically it's split in a deep lamina and superficial lamina, which attach about the lateral and medial margin of the zygomatic arch. Then distally, this fascia continues with the parotid masseteric fascia, so with the fascia that cover the masseteric, and also continue distally with the superficial layer of the fascia of the neck, and specifically we can see some connection with the sternocleidomastoid muscle. The parotid masseteric fascia is the fascia that cover all the masseter muscles, and basically originating from the zygomatic arch and continue with it, is also in continuity with the temporalis fascia, cover the masseter muscle, and insert over the periosteum of the mandible, but more importantly, it goes basically distally and cover the muscle and continue with the sternocleidomastoid muscle. The pterygoid fascia is also a very important fascia that covers the medial and lateral pterygoid muscle. It's a fascia that is important because it's in continuity with the capsule of the temporomandibular joint, and also the entire medial side of the TMJ and the articular disc are attached with the lateral fascia, the fascia of the lateral pterygoid muscle. Another area is in directly contact with the articular disc, so it's thought that also this muscle and this fascia of the pterygoid muscles can influence also the position of the articular disc. Then we have the buccopharyngeal fascia that has a distinct layer and envelope the buccinator muscle and also the superior pharyngeal constrictor muscle. And this fascia basically is a fascia that functionally can be considered a fascia that acts over the masticatory muscle and also has a mimetic function. And also it's a fascia that could be considered sort of the origin of the visceral fascias. And as we said, the temporomasseteric fascia, the parotid masseteric fascia, continue with the fascia of the neck. So in the neck, the deep fascia of the neck is quite well studied and has a three-layer structure with a more superficial layer that is basically more related to the muscles such as the sternocleidomastoid, the trapezius, a middle layer and a deeper layer. And we can see clearly here the continuity example from the masseteric fascia and the superficial layer of the fascia of the neck. So the superficial layer, which is also named as the investing layer, basically is a superficial layer of the deep fascia of the neck. It's around the neck a sort of collar and is basically connected to the sternocleidomastoid muscles, and also split around the trapezius, so it's also involved in the trapezius. And here we have direct connection through the angular ligament with the fascia of the masseteric muscle. So even from this anatomical connection, it's quite clear that, example, the neck may play a very important role for the TMJ in terms of pain, but also in terms of possible origin of the problem that most of the time is more distal to the actual area of the TMJ itself. Then we have a mid layer, which cover basically the splenic muscle, the levator scapula, the rhomboid, and serratus posterior superius, is in continuity with the middle lamina of the thorax, and it basically attaches to the posterior surface of the periosteum and the clavicle, and also surround the sheath of the subclavius muscles. And this lamina of this fascia of the neck, the middle lamina, also create the visceral space. Here we can see some image again. Here the sternocleidomastoid muscle and superficial layer is lifted up. We can see the scalene muscle here and the mid lamina of the deep fascia of the neck, the yoid muscles, and also the sternioid muscles. The deeper layer basically is the deep lamina that is also referred as the prevertebral fascia, and they cover the vertebral muscle and also the scalenus anterius and medius and posterior, all the scalene muscles, and also as posterior portion that cover basically the muscle of the retrospine, the longissimum, the semispinalis muscles, and also the deep fascia, the deep muscle of the neck. So from this, from the fascial anatomy of the neck and the skulls, and also the face, we can see that there is a clear connection between the fascia, example of the temporomasseteric fascia, with especially with the superficial layer of the deep fascia of the neck, which is also in continuity with the superficial layer of the deep fascia of the trunk. So we can found anatomical connection until, example, the area of the pectoralis, or more distally to the rectus sheath or the external obliques. Now, what are the temporomandibular disorder, or TMD? Is a name that basically is a sort of umbrella name that cover many different musculoskeletal and neuromuscular conditions that involve the TMJ and all the surrounding muscles. It affects around 15% of the adult, according to different epidemiological studies. The etiology, of course, is multifactorial, so we have biological, we have social, emotional, and also structural component. It's one of the most prevalent causes of fascial pain. And in terms of signs and symptoms, we can usually observe pain, refer pain into the region of the face, change in the bite, also a worsening of the TMJ during the chewing or eating, a limitation of the joint movement, and also pain that can irradiate to the head, the ear, and the teeth. Most of the patients, as most of you already know, they discover that they have temporomandibular disorder because they go to the nose and throat doctor, referring pain or a strange sound or sense of fullness in the air that is basically just a symptom of a temporomandibular dysfunction. And of course, we can have the clicking of the joint. That itself is sometimes considered parafunction, so it's not one of the signs that is used to make a diagnosis of temporomandibular disorder. Of course, many comorbidities can be present. One of the most common are headache, neck pain, myofascial pain, stiffness, even more chronic fatigue syndrome. Lately, in research, we also see that most of the time the temporomandibular disorder is classified as a chronic pain, even of possible nociplastic origin. So it's a pain that most of the time it appears in the TMJ, but it's just an area of a more chronic condition. The most common, again, a headache, but also the ear fullness symptom is quite common. This type of condition is particularly because we see from the epidemiological study that also is more prevalent in younger people. Even if clinically, we can see that most of the patients are chronic and even they present as a second comorbidities together with a more generalized chronic pain. The classification usually is used using the TMD or the RDC questionnaire, which basically consists of two axes. An axis one, which is more focused on the structural change, so pain, the range of motion, the palpation of specific areas, the biting, and then a second axis that is more related just to the psychological and social components. So even from this way of evaluating the classification of TMD, we can see that also the psychosocial component is quite important in this type of condition. For the axis one, basically, usually we have a division in different groups. So after the evaluation, the patient can be classified in different groups. So a group one, which is usually related to muscular disorders such as myofascial pain with limitation of range of motion. The group two, which is patient with this displacement problem, with reduction, without reduction, with limitation or without limitation. And group three, which are the patients that present some joint disorders like arthralgia, arthritis, arthrosis. The type of intervention and treatment in literature, we see that there are different treatment options from physical therapy, exercise, use of medication, infiltration, and even surgical intervention. However, due to the multifactorial nature of the condition and also due to the different possible region, we don't have a clear treatment for most of the cases. And this type of condition, different to the other condition, also the manual therapy have a quite high efficiency. There are also some multimodal treatment, like described in the study, where basically they suggest intervention that include manual therapy, exercise, also pain education, also cognitive behavior, because we see that most of the patients that also have temporal mandibular disorder, especially the chronic patient, have also a high prevalence of kinesiophobia and catastrophization. So most of these patients, especially the chronic one, they basically also have fear of opening or eating, example, more solid food. And this also we will see also as a comment for our study that we did in Rio is something very important, because most of the patients also need to go through a retraining of the actual function, especially the patients that are more in a chronic phase. So in literature we found different meta-analysis also that show that musculoskeletal manual approach can have a good effect on temporal mandibular disorder, like this study here from 2016. This is also the study published in 2006, which was a systematic review for the effectiveness of physical therapy for TMJ. Basically, they show that there is evidence for manual therapy in combination with active exercise to reduce pain and improve oral opening. Also, this other one that showed that active exercise and manual mobilization, or a combination of active exercise, manual therapy can be very effective for temporal mandibular disorder. Also, this other study was published last year, that a study that was a systematic review that evaluate the manual therapy in the maximum mouth opening and disability in patients with temporal mandibular disorder, which was a study published by a group of researchers from Brazil that showed that there were moderate to high evidence in favor of manual therapy as a standalone therapy for disability, and also as an adjunction therapy for disability, and also for the maximum mouth opening, moderate to high quality evidence in favor of manual therapy alone. So we can see that manual therapy can be very effective to reduce for the reduction of pain, but also to improve the function, especially for the maximum mouth opening. And here we have the first study was published using fascial manipulation, which was published more than 10 years ago by Antonio Stecco, where basically they treated the patient, and one group received botulinum injection, while the other group received a session of fascial manipulation. This study had a follow-up also 3 months. And basically, the two treatments seem to have almost the same effect, equal effect. The fascial manipulation was slightly superior to reduce the pain, and botulinum toxin was a little superior to increase the range of motion after 3 months. It was a very interesting study because it showed that very low-cost intervention compared to botulinum therapy was able to have the same result, especially in terms of reduction of pain was actually quicker. And this is something that is particularly interesting. This is our study that we published in Rio de Janeiro. Basically, in this study, we included 28 patients. One group of patients received fascial manipulation intervention, while the other group received mixed modality intervention, mainly based in odontological intervention. So we included patients up to 75 years of age. So we included patients basically from a wide range of the age group with a chronic pain more than 4 months with a positive RDC and TMD questionnaire. We excluded patients with a psychiatric condition, fibromyalgia, neurological, rheumatological disorder. And we evaluate the patient with the VS scale for pain. As an odontological evaluation, we used part of the RDC questionnaire, more specifically the mouth opening, pain-free opening, unassisted opening, the maximum assisted opening, so the opening until the patient feel any discomfort, the range of motion of the assisted opening, so the maximum opening also made by passing by the dentistry. And we also use the MEG evaluation for the basal and also the maximum voluntary contraction for the masseter and temporalis muscle. So we had 28 patients with positive RDC questionnaire and classified as with Axis 1. In this study, we ended up including patients from group 1 and group 2 and even group 3, so we didn't distinguish from group 1 group and group 2. So from patients which are more related to dysfunction, which is more related to the muscle condition or more articular. In this one, we included mixed patients, which is something quite different from the majority of the studies that use manual therapy, where usually they include more patients from group 1. So the patient from group 1 of the TMD classification, so patient with muscular disorder, and more specifically myofascial pain. This patient received, the group of patients, the study group received fascial manipulation of 5 weekly sessions of fascial manipulation. We treated this segment from caput until to the upper limb, so until the carpus region. And the other group received basically mission occlusion appliance, so the myorelaxant appliance, which were adjusted for 5 weekly sessions, and then dry needling of the mastocytoid muscle and also anesthetic injection of the trigger point. Here we can see another table of different intervention, and it's quite interesting that to understand that we will see also from the follow-up result the patient that were in the odontological group use the appliance for up to 6 months, where the group of patients that underwent fascial manipulation only received 5 interventions, so treatment that lasted just over 1 month. Here we can see some of the table, unfortunately a little bit small about the result, but basically both groups had a statistically significant difference in terms of VAS scale between before and after the treatment, also at the follow-up 6 months. And also we observe difference in terms of the pain pressure during palpation. And in terms of the electromyography evaluation, we observe that the patient at the beginning of the treatment, especially the patient that had densification pain, limitation of range of motion, had a higher myoelectrical activity at rest, and when the maximum voluntary contraction was asked, the patient did not have a good myoelectrical activation of the muscle, which is something similar that also is found in other study example, also for the trigger point. So when we have a densification of alteration in the fascia, we have a higher rest activity, and we have a decrease of tension. So the muscle and the fascia and the muscle appear rigid, but are muscle that don't have a good function. And after the treatment, we had a decrease of the rest activity and an increase of the muscle, the maximal voluntary contraction. Probably this we could explain this also probably from the connection that we have from the muscle spindle with the epimysial fascia. So our conclusion that the FM could be a very effective method for fascial pain, which is rapid, fast, cost-effective, and can give a good improvement in terms of pain, but also in terms of function. And what we also saw that the patient that received fascial manipulation had a quicker improvement in terms of range of motion. So it could also be used as an adjunction therapy for the normal odontological intervention, especially for the patient that have a very strong limitation of range of motion, that also is difficult for the dentistry to do, and also to use the appliance. So now the question is when we could use, example, a fascial manipulation approach or a fascial approach alone or as a multimodal treatment. Well, we have to also, to respond to this question, we also have to observe something, that most of the patients, even when they improve, they tend to avoid the mouth opening. And this is something that also we observe in our study, because basically we saw that from analyzing the data, that the patient dropped from a symptomatic condition to basically an asymptomatic condition. However, some of the patients during the test for the assisted opening, the maximum assisted opening, the pain-free opening, we saw that basically the limitation of the movement, the real limitation of the movement improved, but some of the patients, after a while, they had a drop in the pain-free opening. This possibly could be due to the fact that the patient in our side did not receive an educational program for retraining of the example of the eating or the chewing. So some of these patients try to avoid movement, probably because of kinesiophobia. We can see also in literature many studies that show the presence of kinesiophobia in patients with chronic TMD. So probably the patient would need a more global rehabilitation approach that also include probably a cognitive behavioral approach to retraining and also to also improve the kinesiophobia and catastrophization. Now, let's try to give some guidance for the treatment of patients with TMD, especially using FM. So for, as most of you are already practitioners of FM, as you know, the beginning, the core of the foundation of the FM is to do a very global interview where we collect information regarding previous dysfunction, previous trauma, previous disorder, or even disease. And this is particularly important to understand the origin of the problem, whether it's ascending, descending, or where it could also be origin, could be also a result, or example, of visual compensation. And generally speaking, the most important segment that should be evaluated regardless the individual history, of course, are the neck, shoulder, thoracic, upper limb. And here we have to ask specific questions, example, asking a specific question about the whiplash injury, chronic neck pain, reduction of range of motion in the neck, also history of previous trauma, surgery, or chronic pain in the shoulder, problem in the thoracic region, example, surgery, chronic pain, but even the presence of visual dysfunction, whether respiratory dysfunction that are older also, of the chronologically older than the TMJ dysfunction example, or the something related to the digestive apparatus, but also trauma in the upper limb, which are very common. And these are very important also to start to do our timeline to understand where the problem originates and to be able to give a more effective treatment. As you know, most of the importance is given to the actual area of the TMJ, but even from the fascial anatomy, we can understand that, for example, it could be quite difficult to treat a patient with a huge limitation of range of motion and intense pain, and starting from example from the area of the masseter of the pterygoid muscle, and due to the fascial connection, maybe it will be more important to evaluate both in terms of movement and palpatory, for example, the fascia of the thorax region. In terms of the most important segment, again, the most important segment probably are the segment of scapula, neck, CP23, and thorax. Again, my suggestion is that you start the treatment distally, or at least from the area of the scapula and collar. We know that around 40% of population that have temporal disorder, they also have chronic neck pain. So in this area, and also due to the connection, if you think, example, all the connection that we can trace from the pectoralis major fascia through the connection with the superficial layer of the fascia of the neck at the level of the sternocleidomastoid muscle and the parothomassetary fascia, if we have a big densification on this area, the strength of these muscles, such as the pectoralis or the trapezius, which will be quite huge and can actually become very difficult to act over this area without first treating and releasing distal area at the level of the thorax, example. Now, which movement we can evaluate? We should use which movement verification we should use to evaluate. Of course, it could be very useful also to check the neck. We already say that there is a high prevalence of neck pain in patients with temporomandibular disorder. So we could start by movement verification of the neck, and also give do some specific tests for the temporomandibular joints. So, example, the opening, closure, lateral deviation, also the protrusion and retrusion movement. We can use our movement that we use in FM for Capo3 example to evaluate the TMJ, and also the movement of the neck in all the 6 directions of the space, in the 3 plane of the space, as also to have a more comparative evaluation also for the neck. We can then measure the opening of the mouth. We can use, example, some value even with the plicometer. We know that are above 40 millimeters considered in a very good state, in normal function of physiological state. Then when we go below the 30 millimeters, we're already in an area of dysfunction. Or more generally, you can see that after open that you can use the finger or the knuckle to check it. Below the 2 knuckles, we're already in a decrease of function. It could be very difficult for the patient also to eat and to brush the teeth, for instance. So, regardless now the previous history, if there is no previous history, where the treatment should start, I would say that at least you should start from the thorax, scapula region, and neck in the first session. So in the first session, usually, if the pain is very intense and there is a huge delimitation or densification, it's more advised to start from this area where we have basically a point that could act as a sort of tensor of all the parothomassetary fascia, and it will be more likely that you can have a good improvement in the neck, also opening of the opening of the TMJ without acting in the area, which is the area of the site of pain of the patient, which could also be more painful for the patient. And of course, remember for the TMJ that you should check bilaterally and possibly treat bilateral to restore a better biomechanic of the TMJ. Then, only in the second, third session, you should treat the area of CP2 and CP3. Again, if there is big densification in the area of the scapula, thorax, and neck, it will be quite difficult to release the point more specifically in the CP2 and CP3. So this should be done at least in the second and third session. Now some suggestions. Of course, those are not protocol, but just guideline. Is more likely due to the action of certain muscles. That example, the point on the frontal plane of the diagonal of anterolateral and retrolateral could be more involved in a problem or to improve the range of motion of the opening movement. Of course, again, the process of the fascial manipulation starts with assessment chart, with an individualized hypothesis, which is then confirmed with the palpatory and movement and palpatory verification. So the exact combination of point is very individual, can change a lot, even if the symptom and also the sign of the patient, limitation of movement are equal, the same in two patients. The combination of point can be completely different because all this process is made through individual evaluation and palpatory evaluation. But those are, of course, statistically more common point that we found, example in our study, that work better for the improvement of certain condition. Or example, if you're talking about pain that appear more close to the joint, or limitation of the movement of lateral deviation, example, probably the horizontal plane could be more common to be found, and also the treatment of this point could be more helpful to improve this limitation of motion in the lateral deviation, example. Or when the patient present pain in the gastric muscles, or more problem of protrusion and retrusion, probably the point in the sagittal plane could be more common. But again, I want to stress that this is not a protocol, because the situation can change a lot. Example, we can have patients with limitation of opening that improve with the treatment of the point of the horizontal plane. And here I just place some points just to write down, some point more related to the area of the TMJ, but most of the time the treatment starts very distally. And a treatment that only includes the point of the example in fascial manipulation of CP2, CP3, probably is not effective. It's not effective. The treatment is very painful for the patient. It will not long last. Because again, if we have densification in other areas which are also anatomically connected to the example, the pterygoid fascia or the parotomasseteric fascia, it will be very important to treat this area first, also to ensure that the result is long lasting. And don't forget also to evaluate the neck to make sure that there is, at the end of your treatments, that there is also a restoration of the range of motion of the neck and an improvement of the neck. So here I will just present a case. So here is a patient that is a 35 years old female patient, which had temporal mandibular disorder for 3 years. The pain mainly appeared around the masseteric area. The pain intensity was very high, scored between 8 to 9, constant pain that gets worse with opening, during sleeping, and during eating hard food. A concomitant pain, we had a neck pain bilateral for 5 years due to the trauma. The pain intensity ranged from 6 to 8, and the worst movement were the lateral deviation movement, according to the patient, and also the movement of flexion. The patient also complained about neck pain around the temporalis area for 2 years, pain intensity 0 to 8, which was with a frequency of around 3 times a week. And this is also an interesting data because most of the patients with temporal mandibular disorder also have a concomitant pain as a neck pain, or it's quite common also to find patients with migraine that also have concomitant pain in the neck and the TMJ. This patient also had plastic surgery, breast augmentation 1 year ago, and all this history of 7 years ago of whiplash due to a car accident. So, in the timeline, the oldest problem was this trauma in the neck due to a car accident that also required immobilization of the neck. After 2 years, the pain of the neck became very intense and chronified, and then 3 years ago started the temporal mandibular disorder. Then we had appearance of the headache, especially in the temporalis region, and 1 year ago, the history of plastic surgery. So in this case, we consider the patient as an ascending compensation coming from the neck in the thoracic region due to the actual trauma, the whiplash, and also the immobilization of the neck. And then the appearance of temporal mandibular disorder, and as a compensation also we had a further compensation the neck pain, the headache. In terms of movement verification, we evaluate the movement of the CP3 and also the neck. And we can see from the movement verification a good limitation with strong intense pain in the movement of flexion of the neck, antecollo, and also in the lateral lateral flexion of the neck, and movement of lateral collo. Also, huge limitation and very painful movement of opening of the mouth and also the lateral deviation. We evaluate in terms of comparative palpatory verification the segment of CL and collo and scapula at the beginning. And we observe from this first palpation densification in the horizontal plane, frontal plane, and also in the diagonal of retrolateral and retromedial. And then we did longitudinal palpation also in the segment of CP2 and CP3 in thorax. And at the end of our palpation, we found a very positive frontal plane, horizontal plane, also diagonal of antelatero and retrolateral. And here are the points that were treated in 3 sessions. So in the first session, we started treatment from the area of lateral thorax, bilateral, lateral scapula on the right, which give a good improvement for neck pain, also from the opening of the mouth, lateral collo bilateral, and also the CF of retrolateral collo on the left. In the first session, we had a decrease of around 50% of the pain, and also improvement of the movement of the neck. And the patient also the second week on the second session said that she didn't have any episode of headache during that week that usually was present around 3 times a week. Also in the second session, we observed an improvement of the mouth opening, of the movement of flexion, lateral flexion of the neck. The second session continued on the frontal plane and also with the point of lateral CP2, lateral CP3, anterolateral CP2 and lateral CP3. So in the second session, we were more able to reach the area of the which is more related to the masticatory muscle and the TMJ itself. And the patient referred a further reduction in pain, and also that she was able to start to eat other food, and there was basically no more neck pain. In the third session, we concluded with the treatment of the horizontal plane with the point of extrathorax on the left, and extrathorax on the right, extracollo on the right, intracaputary bilateral, and extracaputary bilateral. So, in this session, in this treatment, basically in 3 sessions, we were able to basically totally decrease the pain, improve the range of motion of the neck and TMJ. So, we conclude our presentation. So I just want to reinforce the idea that the treatment should be more global. It's very important to do a very, very well done evaluation. We ask specific information about previous problem, previous trauma, previous surgery, also internal dysfunction that could be the origin of the problem with TMJ. Ideally, for a chronic temporomandibular patient, the treatment should be multidisciplinary. So if you can work together also with a dentistry, dentistry will be very helpful. And in some cases, especially in the chronic patient that also present conditions such as kinesiophobia, or example, catastrophization, maybe even a psychological intervention together with the physiotherapy could be very helpful to really give a long-lasting result. And we should also not forget about a retraining of the eating example to help the patient to start to, by decreasing of the pain and improving on the function, to start to reintroduce more harder food, and to don't be afraid about opening the mouth example. And what's the main advantage of an approach such as FM is that we can also work in concomitant pain. So most of these patients have a concomitant pain and limitation in the neck, Also, they present with migraine or headache, so we are able also to give improvement also in the concomitant pain and comorbidities of the patient.